Bye.
Thank you. Bye.
Medicine, GNB in Medicine, FRCP London, and GNB in Cardiology. Sir's special interests are structural heart disease, TAVR, Mitra clips, and CAVI. Sir has performed the first Mitra clip cases in Western India, and now he'll be talking about the choices of patient of Mitra clips as therapy for heart failure. Here you go, sir.
Welcome, sir, for a good lecture. I think it's the first time I'm going to hear this. Thank you very much, sir.
Wow. Well, right at the onset, let me thank everybody in GCDC who've put together a wonderful conference. Some fabulous lectures I've been hearing since morning, and some fabulous orators who've been giving these talks, really high quality academic content. Well, Mitra clips is something which is close to my heart, and I just think it's very important for us as physicians to understand which patients we should be offering advanced therapies for heart failure, because now as our academics and our scientific knowledge goes ahead, we have a lot of therapy options which are available for patients with heart failure. We know the drugs that are used for heart failure, but beyond the drugs, when patients are not controlled, are there certain other structural changes which we can offer these patients? And Mitra clip is just the first of the lot which can be offered. So I'm going to talk about this subset of patients which have mitral regurgitation in the setting of heart failure. So mitral regurgitation is really frequent. It is seen in more than 3 million patients in the US, and the most important thing about mitral regurgitation, we all seem to think mitral regurgitation is rheumatic fever or rheumatic heart disease or mitral valve prolapse, but it is in fact the most common reason for us to have mitral regurgitation is secondary. That is, it is related to the anatomy distortion or to papillary muscles or chordae dysfunction, of which the most important cause is actually LV dysfunction and dilatation of the heart. So anything which produces an LV dilatation, which is most commonly ischemic cardiomyopathy or dilated cardiomyopathy, can lead to a secondary MR, and this is the most important cause of mitral regurgitation. Now, the fact that you have a weak, failing heart, once it stretches and the MR increases, automatically the load on the heart will increase. It will lead to a reduced forward cardiac output, hemodynamic compromise, and it will obviously lead to cardiac decompensation. Now, why is this related to LV dysfunction? Because the mitral valve apparatus is not just the leaflets. When we talk about the aortic valve, the pulmonary valve, we talk just about the leaflets, the annulus, the calcium. But in the mitral valve anatomy, you have the leaflets, which are themselves divided into 6 different components in the anterior and posterior leaflets. You have the annulus, you have chordae, you have papillary muscles, and you have the commissures. So this entire complex forms the mitral valve anatomy, and any of these things can cause a dysfunction. So the list of causes is really long, and of course rheumatic fever, rheumatic heart disease, connective tissue disorders do form an important part, infective endocarditis. But for the reason of today's talk, we'll divide mitral regurgitation into primary and secondary. Primary being an organic or a problem with the leaflets or the valve itself, and secondary being related to something which spares the leaflets but affects the atrium or the ventricle, which is what I'm talking about in the ischemic and dilated cardiomyopathies. So this is an old classification of mitral regurgitation, where in type 1 you have a normal leaflet. So these patients have normal leaflet motion, but it is caused by dilatation of the anatomy, and this is the subset which we are going to discuss today. Type 2 is where there is excessive leaflet motion, that's in mitral valve prolapse, and type 3 is when it is restricted. This also can sometimes happen in ischemic cardiomyopathy, where if one part of the anatomy of the LV, like the inferior wall for example, is restricted, then it will not allow that part of the mitral valve to contract well, and it will lead to a tethering of the valve and dysfunction, and therefore mitral regurgitation. Now, as far as the pathophysiology goes, any kind of ischemia, LV dilatation will lead to LA dilatation, papillary muscle dysfunction, inadequate coaptation of the leaflet, And like I said, the LV remodeling may be regional or it may be globular. And this will lead to, the most important thing is what is in this black box: increased LV EDP, increased left atrial pressures, and subsequently increased pulmonary venous and pulmonary arterial pressures. And that venous and arterial hypertension is what is responsible for the breathlessness and the heart failure that we keep looking at. Decreased cardiac output and hemodynamic compromise. So once the person with chronic heart failure develops mitral regurgitation, that's when the heart failure symptoms will really worsen. The entire hemodynamic profile will change. The LA will enlarge. They will get atrial fibrillation. The pulmonary vasculature will change. The pulmonary hypertension will develop, and they go really downhill from there. How do we diagnose this? The most important is our transthoracic echo, where not only are you looking at the LV function, but the diameters of the heart. So before the LV function reduces, sometimes the actual diameters will become bigger. So we actually take a cutoff of the end systolic diameter more than 40. That tells you that the heart is now not working well enough. There are volumetric parameters and PA pressures which are also taken into account. A very important thing which has changed is the advent of 3D transesophageal echo. So 2D and 3D echoes have changed our quantification and changed our etiology determination. So with a 3D and a 2D echo, you can actually determine, is this primary mitral regurg or is it related to a secondary problem which is LV dilatation. And during a procedure of Mitra clip, that is when this really comes into play, and I'm going to show you all why. Cardiac MRI and our blood investigations of BNPs and NT-proBNP also come into play, and they are involved in our decision making process. Because what is important to understand is even the moderate mitral regurgitation, if you have a patient with moderate MR on echo, but you see that their BNPs are rising, then it's very worthwhile doing a transesophageal echo, because on TEE you might find that this moderate is actually a little worse, and that might push us towards getting a mitral clipping done, which will reduce the risk of heart failure in the future. So if you can see the, not play, alright, nevertheless, so this is a transesophageal echo, and this is what it looks like on the 3D TE. So if you can see, there is a this is the part of the mitral valve which is prolapsed. If you can see, this is the leaflet which is prolapsed, and that is evident in this part here, where the regurgitation is the red part which is coming back into the LA. Okay, so coming into the guidelines, now although these charts look really complicated, what we should understand is that you divide MR into either symptomatic or asymptomatic MR. Once you have a primary mitral regurg, like this is, imagine a patient with mitral valve prolapse. Once you have a patient of primary MR who has symptoms, they need to be operated. Now, the operation can be a mitral valve repair if they are fit, because that is a corrective surgery. But in case they are not fit for surgery, then you offer a Mitra clip, which is called a transcatheter edge-to-edge repair. So only, again, important is that if they are fit for surgery, mitral valve repair is still a class 1, whereas the mitral valve repair is a palliative procedure for patients who are not fit for surgery. On the other hand, if you have patients who are asymptomatic, only if you have worsening parameters, reducing LV functioning, dilatation of the heart, that's when you need to get into surgery. Now, secondary mitral regurg is a different story altogether. Secondary mitral regurgitation, imagine a patient with dilated cardiomyopathy. They have a very dilated heart, and we are now progressing these patients onto the best medical care we have. All the medicines, the newer ones of ARNI, the SGLT2 inhibitors, Vericiguat, add everything you possibly can, because guideline directed therapy is the best for these patients. If on these they are still worsening and you find a mitral regurg, these patients are by and large going to be your inoperable patients, because they are going to be not fit for surgery with an ejection fraction of 20% or a rising creatinine. So these patients you will offer a mitral repair, because they would be a better candidate to undergo a non-invasive procedure as compared to an open mitral valve surgery. Now, mitral valve repair has got a lot of things you can do. So a surgeon can also do a lot of things when they repair the valve. And again, I want to emphasize that this is the gold standard. But the percutaneous therapies have also come into the market, and they are really very well, they're available and they really need to be highlighted. So although there are a large number of things in the pipeline, from devices which reduce the size of the annulus to these clips, the Mitra clip has actually been approved. It's based on an old surgical repair where the surgeon would stitch the center of the leaflet and make the mitral orifice into two holes. That was called the Alfieri stitch, and it is now converted into this concept of Mitra clip. Now, what exactly happens? Can you click on this? Yeah, so as you all can see here, this is a normal mitral valve and it is opening and closing. Does not allow, this coaptation means the leaflets join well together. There is no regurgitation. And this is mitral valve where it's been stretched. So part of the leaflets don't come into contact, and this leads to mitral regurgitation. So since that part doesn't contact each other, why don't we pull those parts of the leaflets together? So it's, you go across from the venous access into the L, from the RA into the LA, get the Mitra clip in, open this clip and clip the part which is not opening, as you all will see here. So you position exactly where there is no coaptation, clip it together and leave the clip. So automatically you've clipped the part which is not working well and the remaining part functions well. This does not lead to a zero mitral regurgitation. It just reduces the mitral regurgitation to a tolerable level. So the idea is not to make it from class 3 and 4 MR to class 0. That is not the plan. The plan is just to reduce it to a 1 or a 2 so that they don't get heart failure. Now, there are a lot of criteria which are more echo-related criteria, but what I need you all to, what I want to discuss is that there are now not just 1 or 2, there are 4 types and sizes of Mitra clips available. These clippers which you'll see, they come in different sizes and in different widths. So based on the actual pathology, you can decide which clip would be better for your patient. These are certain things which you see on the transesophageal echo, and well, I won't get into that because they are real technical parameters, but it's important that you see it from the TE and the 3D TE point of view, which will then decide what you need to do in terms of the clip. Now, this is the big delivery system, which you all can see here, is actually, it's a very cumbersome and it has a lot of physics in how to maneuver this clip. So there are around 5 or 7 knobs which you can move the clip anteriorly, posteriorly, to the left, to the right, go up, go down, because you need to maneuver it exactly over that point into the left atrium. Now, how do you do that? I'll go through the procedure in quick, because again it is a little technical, but you put the patient under GA. It can be just deep sedation. A 3D TE is an absolute must, and we go from the right femoral vein. Now, the second you come into the venous route, your risk of complications in terms of the groin go down significantly. The first thing you do is you do a transseptal puncture, which is done via, if you all can see, this is actually, when we are in the cath lab, we also have a view like this, where the TE is on top and you have the fluoroscopy running down. If you'll see the tip of the needle there near the TE probe, the second you have a TE which shows that, okay, I'm in the right point, the fluoroscopy, with the fluoroscopy, we guide the needle forward and we know that, okay, this is not going to harm the heart and this is the correct point for the puncture. So you go from the right atrium into the left atrium and okay, yeah. So you go from the right atrium to the left atrium. So you create a tiny ASD there. Through that ASD you pass a big sheath or a guide. This is a 24 French guide which is passed and kept into the left atrium. Now from there, as you all can see here, the Mitra clip is advancing into the guide, and once this is into the left atrium, now this guide is in the LA. So once it is in the LA, you can see that with those knobs that I spoke about, you can maneuver it. As you all can see in the movie there, it's opening, the clip is opening. All this is done in the left atrium. And subsequently, the clip is advanced across the mitral valve into the LV. Now, how do I know this? On fluoroscopy, you can't see the mitral valve. And the answer is that you need to do that with the TE. So actually on top, you'll immediately see a TE which shows, you see the TE picture here, that the clip is right in the center there, and you can actually see exactly where it is going down. So here, this is where dye and contrast has no meaning at all. All you need is a good fluoroscopy image, and you need a good transesophageal echo. So your echocardiographer is really your best friend in this procedure. And the clip, you can see in this, passes down, you see exactly where the leakage is, and you release the clip finally once you're sure it's in the right place. As you can see there, it's released in the heart, and I wish I had those movies which could run to show you all exactly how this looks, but nonetheless. So this is the heart with the clip, the single clip, and this patient, immediately on the table itself, you see these are the parameters where you are looking at the Doppler values into the pulmonary veins. And initially, you demonstrate that there is leakage and flow in the veins in diastole. But as soon as the procedure is over, you see that there is absolutely no flow in the veins, which implies that the mitral regurgitation has completely stopped. So sometimes you have patients where one clip is not enough, and you put two clips side by side, as you can see there, and that is sometimes meant to reduce the regurgitation a little more. That happens when the non-coaptation is a little more. Now, there are a couple of trials which I will quickly go through in just a few seconds. The Everest trial started the Mitra clip bandwagon, and it was just said that, look, this clip can be done in humans. It is done well without any major complications. Everest 2 is what suddenly made the entire procedure very safe and very efficacious, because it compared the clip to the surgery. The COAP trial is what got us into the guidelines, where it was found that it actually changed when you kept people only on medications versus with a clip. So it showed that doing nothing is really the worst option for these patients. And you have certain other trials which came in and helped the cause as well. Contraindications and complications I won't get into because they are again technical. But to conclude, I'd like to say that this is a revolutionary procedure. It has changed the way we treat our patients with heart failure. The important thing is that we recognize patients with secondary MR not only to be ischemic but also dilated cardiomyopathies, and to see that this mitral regurgitation is actually a very large component of heart failure. So if they are not operable, if they are on maximum medications, the best option would be to see that the MR is corrected. This has been proven in trials, and now it's been included in all our guidelines as well. Now it's just important that we embrace this topic, and using an entire team of doctors, you have cardiologists who are non-invasive heart failure specialists, you'll have your transesophageal echocardiographers who will tell you about the feasibility, you have surgeons who will tell you whether they are surgical candidates or not, and then you'll have the interventionist who will finally say, okay, if I can't do anything else for this patient, the clip is a good option. And with this, we should expect many more people to live longer lives with the clip and with subsequent procedures which will also change the face of heart failure management. With that, I'd like to thank everyone in GCDC for a very lovely conference, and it's been an absolute honor to talk to this audience. Thank you.
Oh, thank you for a nice lecture. In fact, it was very eye-opening to see a new procedure. So since morning, you've been discussing a lot about failure, heart failure, and so on. The august audience clearly knows that the heart failure is really a big problem, and the patients do get admitted quite often. Economically, it actually drains the patient. So from your talk, I just want to know, the resistant cardiac failure, when the patient becomes totally inoperable and so on, when we have tried all the medications, does this actually, how long will be the time taken once you put a mitral clip? Probably, does it postpone the requirement of cardiac transplantation? That will be people always say the transplantation is the last step. So is there any gap? Like, is it able to really postpone the transplantation for some time? Or, and next question is whether the clip will fall, all those things, how are you going to manage this?
So, well, if we talk about a patient who is well managed, a dilated cardiomyopathy, once they are not controlled on medications, the next step for them should be a transplant, not a Mitra clip. This is the younger patients who are within that 60 or 65 age group who will tolerate a transplant, because the transplant is more like a curative approach for them. Of course, transplants come with their own problems, but if you compare a Mitra clip to a transplant, the transplant is still a better pathway to go down. We are talking about the patients who are beyond that, who cannot undergo any more medications, who are done with their diuretics, who cannot undergo even open repair, and for them the clip is a good option. So if you have a younger patient who is got a LV dysfunction, maybe mitral valve prolapse, and they can tolerate the mitral valve repair surgery, they should still be a good candidate for surgical repair. It's when you are inoperable when this comes into the picture. So for, let's say, a 75, 80-year-old person, this procedure will have no dye requirement. They are very safe in terms of the groin. You can do the procedure at your own ease because you're in a low pressure system. You're in the LA. Most of your time is spent in the left atrium. So there are no hemodynamic fluctuations. There are no blood pressure fluctuations which occur. So the patients tolerate the procedure very well. It's venous, so you come out, and once you're done with the clip, it's as if the patient can actually stand up and walk in around maybe by the next morning. And usually we discharge these patients in a day or two. Within a couple of, I would say a couple of days to weeks, we start seeing them reducing their diuretic dose. We start seeing them having a far better functional capacity. So even though the cardiac function may not change, but their functionality really changes significantly. And it lasts for a long time.
Thanks a lot, sir. Thanks a lot. Thank you for nice lectures.
Thank you so much.
Thank you, Dr. Pichmani sir, for wonderfully chairing the session. I also thank Dr. Cynthia ma'am and Nihar Mehta sir for their great talk. Now I invite Dr. Nagarajan sir, HOD of Department of Medicine from Satya Sai Medical College, to chair the next session. Luigi Nudi, Professor